Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com. It is August the 12th, 2016, and this is the RheumNow Week in Review, where we review the highlights from this week's publication of RheumNow, delivered to you daily in your daily digest. If you're not getting this, you could get this by signing up at the website. So some important news from this week. Beginning with the social media feed, you'll find a link to a video that I did about the pearls of methotrexate toxicity management. This was done at the recent RNS meeting, the Rheumatology Nurse Society meeting held in Cleveland last weekend. And that video is featured on the Helio website, and you can find it on our website and also on my Twitter feed. There's also a great review in this week's journal, New England Journal of Medicine, by Fred Weegley and colleagues talking about RheumNow. It's a good review of RheumNow's phenomenon, its diagnosis and management. A nice review, mainly for patients, is out there, and you might refer your patients to it, about patients who have seronegative RA and what that means. It explains that the importance of testing, how you can have the diagnosis without having the rheumatoid factor and CCP antibodies, and then what those tests mean to long-term outcomes of patients. For patients who have expired drug or dangerous drugs that need to be disposed of, one, they shouldn't throw it down the toilet. Number two, they probably should throw it in the garbage. But if they're worried about that, there's a new offering from Walgreens. You can go to a Walgreens drugstore, and they have kiosks set up for drug disposal, and that can be a real aid to a lot of patients. Next, there's a nice report from Japan that talks about how frequently their patients persist on biologic therapy, and interestingly, their rates were quite high, and that may relate to a lack of other options, but it was highest in patients who were biologic naive, more than 95% retention, and it was lowest in those who were older and had a lot of comorbidities. I don't know what you do, but patients who have osteoarthritis of the hands or knees, especially if it's inflammatory erosive osteoarthritis, I don't have a lot of options. In fact, I'm quite frustrated, and there's really a dire need for more research in this area. I do know from personal experience biologics don't work, DMARDs don't work, and I often end up relying on low-dose prednisone to manage them along with other analgesic agents. Again, there has to be some research on that because the available research right now is quite conflicted. Some saying it may be beneficial, especially with knee OA, or not beneficial in hand OA. But we need new options. We need more research in this area. A 9-year study of patients with inflammatory myositis looked at the long-term outcomes in that group. They found that 25% of that population died in that time frame, and that the leading cause of death was infection, which occurred in 30% of the patients. Predictors of death with myositis were the presence of lung disease with myositis and the presence of infection, not surprising. This is a single center study, but still quite instructive. And lastly, a teaching point about hip pain. A lot of people complain of hip pain, but very few people have hip pain. Number one cause of hip pain is buttock pain. That accounts for about 75–80% of patients. It's felt where your wallet is. It's almost always from being referred from the lumbosacral spine. So it's a spine problem. The number two cause of hip pain is trochanteric pain. You point to it with one finger, it's on the side. It may radiate a little bit, it may hurt when you have movement. This accounts for about 15% or 20% of hip pain, and that's from trochanteric bursitis or trochanteric pain from a fibromyalgia tender point. And the last cause of pain, number three, is groin pain or anterior pain, and that is actually the true hip joint. This is a minority of patients. Somewhere less than 10% of patients who complain of hip pain have true hip pain from the hip joint. Other news, there's a nice report from the BSRBR, the British Biologics Registry, looking at the risk of lymphoma in patients on TNF inhibitors. Everybody's concerned about lymphoma, but again, I've been preaching for years, the risk of lymphoma with TNF inhibitors is the same as the risk of lymphoma from RA. RA imparts a number of risks as far as cancer, lymphoma probably being the highest, but lung cancer, skin cancer, etc., are high in RA patients, and colon cancer and breast cancer are lower in RA patients. Guess what? Give an RA patient a TNF inhibitor, you see the same pattern, the same risk factors. So they looked at their population, which compared 3,300 patients on DMARDs, followed over a long period of time, with almost 12,000 patients who were on TNF inhibitors, and they showed no risk. I mean, the odds ratio was 1.0. No risk of developing lymphoma if you were taking a TNF inhibitor. Again, reiterate, it's your job to take care of the arthritis. Let the cancer doctor take care of the cancer. An interesting report also comes from a commercial claims data set, which looked at over 8.5 million insured lives and tried to figure out how commonly RA patients get dementia, or specifically Alzheimer's. There's some belief that inflammation may play a role in the pathogenesis of Alzheimer's. And what they did find is that RA patients have almost a 7-fold increase in the risk of Alzheimer's. RA patients with a 0.79% prevalence of Alzheimer's, whereas those patients in the database who they compared to who do not have RA only had a 0.11%. So almost a 7-fold increase in RA patients. Interestingly, they found that there were other factors that caused or contributed to risk, and that included coronary artery disease and diabetes and peripheral vascular disease. When they looked at the RA patients on TNF inhibitors, they showed a significant decrease in the risk of Alzheimer's. But more specifically, the risk was largely seen with patients who were taking etanercept and not with the other TNF inhibitors. So the overall risk imparted by a TNF inhibitor was an odds ratio of 0.45, which was low, but it was much lower and more significant for etanercept, where the odds ratio was 0.3. What is it about etanercept that makes it superior to adalimumab and infliximab is not known, and this is an observational study that requires more observation and more study. Two more reports, the cryptochromes regulating circadian inflammation. I found this interesting, if not surprising. Cryptochromes are flavonoid proteins, plant-based proteins that are involved in a number of different functions, including photosynthesis and circadian rhythms in mammals. And what they showed is that during the dark hours, that there is a suppression of inflammation in animal models, such as the collagen-induced arthritis model, and that a lot of that seems to be mediated by two cryptochromes specifically. So again, these are maybe important targets for future therapy, and maybe these cryptochromes not only regulate circadian rhythm, but symptoms such as morning stiffness and rheumatoid arthritis. EULAR has issued an update to its gout guidelines. These new guidelines are very much like the old ones, or very much like the current ACR guidelines. There are 11 new recommendations in there, things that you would expect, but for instance, that patients who have an acute flare that can be managed with colchicine. Why they recommend colchicine, I still don't know why anybody would, but nonetheless, if not colchicine, non-steroidal steroids, and even IL-1 inhibitors. They do recommend that everybody should be considered for urate lowering therapy with their first attack, and that patients who do go on urate lowering therapy should have prophylaxis. And they also make the point in there about patients who go on allopurinol need to have renal adjustments, or adjustments for renal function. We've known in recent years that actually you don't need to adjust for renal function very often, and that patients who have impaired renal function with creatinine of even 2 or 3 can almost receive normal doses of 300 or 400 milligrams a day. You need to monitor their patients more closely if they have renal impairment, but you still can use near full doses unless they get into severe CKD, stage 4 or above. Lastly, there's a nice blog that I wrote about my nurse practitioner. I wrote this because I was going to a nurse practitioner meeting, and I wanted to talk about the importance of nurse practitioners in managing patients with rheumatic disease, especially in my clinic. I received a lot of feedback from a lot of nurse practitioners, a lot of rheumatologists who employ nurse practitioners and physician assistants, saying it's a wonderful way to expand the capabilities of your clinic. Look at that blog if you want to see my perspective on nurse practitioners. That's it for this week. You can go to the website to get the citations and links to these reports. Be sure to follow the wonderful, exciting world of rheumatology on rheumnow.com. Register and continue to see that good news. See you next week. Bye.